We turn now to the Chief Executive's report. David.
Thank you, Chairman. And just to reinforce some of the things that the Chairman was saying earlier on, we're now in a position where most of our staff have been appointed. Most have been are in post now. I know that Joe's going to talk about some of the HR issues later. We made a commitment as an executive team to go out and meet our staff, both in the National Support Centre, but more widely in each of the area teams over the period. By the end of May, we'll have done almost every area team. I think there are two or three things I'd say about that in terms of the feedback that I'm getting from it and where we are. And I think just to reinforce again the point that the Chairman made about the number of staff that we've got is actually half the number that were doing the jobs that they're doing in the previous arrangement. So a massive kind of effort of job redesign and service redesign is required to enable us to deliver the efficiencies. And the other thing that has contributed just itself over £500 million worth of savings, which are being reinvested in frontline services. So, a big but really important thing for us to do as part of these changes. So we've been visiting the area teams, and for those people in particular who were either working in SHAs and PCTs, I think you have to recognise the kind of the journey that they've all been on for the last since the government announced the abolition of SHAs and PCTs. Not only have they had to build the new organisation, they've also had to make sure that the NHS continued to improve services for patients, and at the same time have been extraordinarily worried about their own circumstances, applying for jobs and all the rest of it. And they have, I think, genuinely done an extraordinary job during that period. And the thing I would say about having been to those meetings is that people are now ready to do something new. They're kind of, because now most of them now are just doing the single job that they've been employed to do as opposed to the 2 or 3 jobs that some people were doing. I think there's an enormous kind of energy and enthusiasm to take things forward. And this is in a sense a moment in time for NHS England, and that's why it's so important when we talk later about getting the vision and the objectives of the organisation right, that we can mobilise people to make great improvements and outcomes for patients. So a really kind of positive set of experiences for me going around. Not to say that there are not operational problems, and there are, whether you look at the way some of the HR practices work, whether the implementation of IT, all of those things. But nevertheless, I think people are enthused and want to get on and improve services for patients. So really reassuring from that perspective. We've also brought together an important group of people for NHS England, which is the National Clinical Directors. We've appointed 25 National Clinical Directors across the country, covering almost every specialty and care group that you can imagine, from psychiatry right the way through to diabetes and obesity. So a big and a fantastic array of people that we have got. 25 people, all working part-time. It's important that for those people, that they continue to do their clinical work, so they're in touch with clinical practice as they go along. Really important that they do that. And we brought them together as part of an induction programme. And again, we've got a fantastic resource there, not only for NHS England, but for the NHS widely, where you've got a whole set of people who have significant national and in some cases international reputations for the kind of clinical work that they've done, and they'll be able to provide support and help to the kind of service change that we need in the NHS going forward, and a real valuable asset, I think, for us as we go forward. Just want to say a thing about a couple of interventions that we'll be making next week. One about A&E and one about clinical commissioning groups. On A&E, Barbara, I think later, is going to be talking about 111 and the impact and implications of all of that. But there's no doubt, if you look across the country as a whole over the last few months, A&E services have been under significant pressure. And all credit to the CCGs, but more probably to the people who work in A&E and emergency departments, how they've worked really hard to keep the service going and to continue to provide decent services for patients. But undoubtedly there is pressure in the system. It's quite hard to get to the bottom nationally as to what all those pressures are. We know that, for example, March, in terms of the weather and the environment people worked in, was much more like a January than it was a March, and we would expect to see improvements in performance in A&E during that period, which we didn't see. Over the last quarter, the number of both emergency admissions and the number of attendants in A&E have slightly gone down, so it's not a number issue. But we know there are real pressures in social care and in primary care and in the way people manage hospitals as they take the services forward. One of the ways that shows itself is in the relatively deteriorating performance in relation to the delivery of a very important constitutional standard, which is people being seen and treated within 4 hours. And we've been working very closely at a national level to see how we can support and help performance in this area with the National Health Service Trust Development Authority, who have responsibilities for NHS trusts, and also Monitor, who have responsibilities for Foundation trusts. So the 3 organisations have been trying to work together to see how we can help and support people working in A&E and A&E services. And we've seen in the last week or so some improvements in performance. But the bottom line in all of this is that this is a whole systems issue. This is we need to improve things in primary care. We need to improve the way in which we admit patients. We need to improve the way in which we support accident emergency departments. We need to improve the way in which we manage internally into our hospitals, and we need to improve the way in which social care and the NHS operate together. So with all that in mind, we'll be publishing next week a framework for plans, recovery plans from within the NHS over all whole system plans that we expect CCGs to put together for their organisations. Many of them are working on these at the moment and getting them right. We want our area directors to be assured that everything that can be done is being done, so we can see an improvement over the next period. And not least of all, to make sure that we're beginning to start to plan for what we know will be an increase in pressure in the system later on in the year as we get into winter. So that will be published. Next week, and we expect we will also provide support to people in putting those into place. So very important, I think, intervention there. The second one is in relation to clinical commissioning groups. One of the things that we've constantly said as NHS and NHS England and before is that part of our responsibility is to support and help CCGs to be the best that they can possibly be. But we also have a responsibility to hold them to account for things that they do, and we plan to publish the assurance framework next week, which is the kind of beginning of a conversation about how we best fulfil that responsibility in a way which develops and supports CCGs, but also intervenes in the right and appropriate way to when things go wrong. So we'll be publishing that next week, and it's a real. We've had quite a lot of discussion with CCGs already, but we want to have more with them, particularly with the commissioning assembly, to make sure that people buy into the general approach that we're trying to make, which is much more about how can we ensure that you can continue to improve great outcomes and quality for your patients locally. So really, I say, an important moment for us next week. The fourth thing I want to say is about safe and sustainable. The changes in paediatric cardiac surgery. We know that this work was kicked off some years ago. NHS England took responsibility for it on the 1st of April. We're involved in discussions around the JR that was laid by from Leeds, But also there is an independent a review panel report into Safe and Sustainable, which I understand is either with the Secretary of State or about to go to the Secretary of State. We don't know what the conclusions of that independent review panel will be into Safe and Sustainable overall. But there's no doubt that whatever that is, and whatever judgment the Secretary of State makes on all of that, there will be work for us to do to take whatever is forward. So the NHS England have set up. We've set up a task and finish group led by the chairman in order to kind of work through what all this will mean to us when we get the information. It's really important, I think, to us, and consistently has been the case that our overriding number one priority is to get a safe and sustainable and excellent paediatric cardiac service for all the children who require it in this country. We remain absolutely resolute to do that, and whatever needs to be done, we will make sure that happens. And as I say, when the Secretary of State sets out his views, we'll be really ready to move in whatever way is appropriate. And then finally, at the last meeting, we had a long and substantive discussion about the events at Leeds Teaching Hospital. I'm pleased to say that the surgery has now been reinstated there, and that it was reinstated in a safe and effective way. People continue to monitor what's happened there. There are still some outstanding issues around the investigation of complaints and around the way the service is organised that we're keeping very close to, and that we will in due course bring a further report to the board to set out where we are in relation to the medium and long term position in Leeds.
Thank you, David. May I invite any issues from members of the board?
I don't know whether Barbara wants to add anything to the A&E.
Well, I can just say a few words. We've worked hard with our partners in Trust Development Agency and Monitor and our CCG partners, and as well as having contact with local government, because they obviously, as you rightly pointed out, they have a major part to play in this. So I'll be writing out, asking our area team directors to take responsibility for the creation of a plan across every health economy around a local A&E department. A plan which looks at the full range of things which can make a difference to getting a better service for patients who need urgent care. As David said, whether those are the things in primary care, in out-of-hours services, how 1-1 can play a part, working with partners who oversee provider organisations about the flows and the things that we can do within hospitals. We will be asking our area team directors to make sure that a full plan is pulled together by the end of May, so that all the partners who we are suggesting that the area team directors bring together in an urgent care board, and that the partners on that urgent care board across that community can ensure that absolutely everything is being done across the health community to make sure that patients don't wait unnecessarily on unreasonable times for their treatment, which is a bad experience. It's not safe, and we know that it has an impact on clinical effectiveness.
Thank you. Right, well, thank you, David, for that report.